Are you able to host, or should I? Can you hear me? Hi there. Apologies for the technical difficulties. Just let me know when you're ready. We have some folks in the waiting room, and then we can get started. Hi there.
Hi, can you hear me?
Yes, can you hear me?
Yes, I can.
Great. There's some folks in the waiting room. Are you ready to get started?
Yes, let me put my slides up.
And just to make sure I get it right, how should I pronounce your name?
Kaushal Solanki.
And the name of your company?
INAC.
Great.
Let me see. Can you see my slides?
Yep.
Okay.
So I'll start letting folks in then.
Yeah, sounds good. Thanks.
Hi, all. Thank you so much for joining us for this afternoon's webinar. We're really excited to have joining us Kaushal Solanki, who is the founder of iNook. He pioneered the development, prospective clinical validation, regulatory process, and commercialization of the EyeArt system for the autonomous detection of diabetic retinopathy. He has a doctorate in electrical and computer engineering from the University of California, Santa Barbara, and has published widely in international journals, with his work cited over 1,500 times. He also holds several issued and pending patents. Thanks again for joining us today, and I'll turn it over to you.
Great. Thank you, Lydia, for the introduction. And welcome, everyone. Good afternoon or good morning, wherever you are. It's a great pleasure having everyone here for this webinar. So I'm going to talk about AI for better healthcare. How can we recognize opportunities, deal with challenges, regulatory and other compliance challenges, and how we dive into the future. I, a bit about myself. I founded INAC back in 2010 with the goal of bringing, AI to the healthcare world. And, this all started with my own personal healthcare. As Lydia mentioned, I'm trained as an AI machine learning scientist back in the day, and I was working at a startup on DoD and DARPA technologies, things that are very cutting edge, but I couldn't talk about. And one fine day, I went to see an optometrist just across the street from where I worked, and he identified me as a glaucoma suspect. He was like, Kaushal, you may have silently developing glaucoma. And I'm like, what do you mean? That was the first time I saw retinal images. And him and I, he's a good friend now, tried to make an appointment for myself with an ophthalmologist, with a glaucoma specialist. But this was in Santa Barbara with very good, healthcare system. But I still had to wait like 4.5 months, and that too, I had like the best insurance money could buy. That was what led me to, there was a nervous times, I researched this more and led me to founding of INAC. I realized how, diseases progress without any symptoms. My father, who had diabetes then for almost 10 years, had never gotten his eyes checked. So, so that this all hit me, that led to founding of this company. Initially, we took a very, very academic, scientific approach, but soon we realized that we could have a huge impact in this world. Fast forward today, we have multiple global regulatory approvals, including US FDA, EU, Canada, many others, for fully autonomous AI. And the idea was that people like me who just see front lines of care like primary care or an optometrist to not or should not need a specialist appointment just for screening, so that um, healthcare can be more efficient, more patients can get access to this kind of screening. Over the years, we had, as I said, globally implemented technology now in 27 countries, over 5 continents. It's the most validated AI in healthcare, very, very large independent studies with tens of thousands of patients, including one study of over 100,000 patients was conducted. We have this technology now reimbursed by CMS through a Category 1 CPT code. And there is a lot of learning that I'm happy to share, over this webinar. And that takes us to the agenda. I'll start with the INOX story, but go into AI in healthcare framework, explain regulatory and clinical and reimbursement implications, go into the future with agentic and multimodal AI, and the challenges and opportunities that bring, and finally summarize this for the stakeholders. So the reason why, as I mentioned, I founded INAC through my personal health scare is because eye is a window to our health. It's the only organ that allows non-invasive imaging of microvasculature and central nervous system. And that is why I believe that retinal imaging with AI is set to be the diagnostic platform of tomorrow. In a non-invasive way, it can allow all these vision-threatening conditions like diabetic retinopathy, glaucoma, macular degeneration, and so on, that progress without any symptoms that could be detected early, but also chronic conditions like cardiovascular risk, Alzheimer's, hypertension, stroke, as well as life-threatening conditions like ocular cancer can all be detected through retinal imaging, through a non-invasive scan, like no needles poking your hands. and this has huge potential to be a diagnostic platform. And that is what we set out to execute at INUC, where the idea is for patient to go to front lines of care like primary care, optometry, any front lines of care, including, let's say, pharmacy chains, where AI can instantly analyze images of these patients without any dilation, producing an actionable report without needing a physician oversight. Um, Over the years, we have had many firsts through our fully autonomous detection of these vision-threatening conditions. Back in 2015, when AI was hardly a thing, we achieved the first deep learning healthcare AI regulatory approval in Europe. In 2020, we were first and only autonomous AI to be cleared by FDA to detect multiple disease levels. In 2021, we expanded it to additional conditions in EU with an MDR Class 2B approval. In 2022, this device class was the first to be reimbursed nationally under a Category 1 CPT code. So this technology has been a pioneer in AI in healthcare, and I'll talk about how we took this journey, how we took this from concept to global impact. We started with the data and IP. We acquired almost 2 million plus retinal images, de-identified images. A number of patents were issued, and early on, as I said briefly before, we took a very scientific approach through funding from prestigious NIH grants. That led to extensive validation, and as I tell people close to me that if I'm going to be working on spending a decade of my life working on this technology, it better work in real world, and that is why we went out of our way to validate this technology in very, very large data sets, very, very large prospective studies. Like, our technology has been subject of the largest prospective AI in healthcare study, achieving 100% sensitivity. We have done prospective multi-center clinical trial with very high sensitivity again, a very large retrospective AI in healthcare study with over 100,000 patients and excellent sensitivity. So that led to regulatory approvals globally. We also created implementation infrastructure, including integration with a number of ophthalmic imaging devices, but also integration with EHR systems, most popular in the US and the world. We obtained a CPT code, a new Category 1 CPT code, and AMA has been very supportive to this technology. We also got this technology to be blessed by all these societies, including, American Diabetes Association and American Academy of Ophthalmology, who include use of AI for eye screening in their guidelines. Also, American Telemedicine Association and NCQA, including this to meet HEDIS and 5-star measures. So a lot of infrastructure that enabled adoption. Finally, reimbursement, major one from US CMS, but also from private insurance, as well as globally, including NHS in UK, who brought out a very large 150-page plus report saying our technology is the only one with enough evidence for adoption in the UK. Also Discovery Health in South Africa. And that leads to adoption with over 250,000 patients screened, 30,000 plus patients with sight-threatening disease found who got their vision saved. This all our work has led to mention and recognition by World Health Organization amongst other bodies. So this has been a substantial amount of work and a substantial amount of learning for me, taking this journey from concept to global impact. And if we take a step back as to, how many ways can AI help healthcare providers, I'll give you my take. The you know uh, First is capture AI, right? Like, so any data that is out there in the world needs to be captured into digital system. Like, so data resides in human body or elsewhere, and we need a clean version, not a noisy version. So AI has a big role to play in capturing this data. Second is what I call spell check AI. So, it's a AI that works in the background, checks for errors as clinicians perform their regular work. And the idea is not to interfere in their work, but just work in the background like a spell check would, or like a, you know, technologies in your car, like that keeps you in the lane. It beeps when you go out of lane, but otherwise it doesn't interfere with your driving. So that's what I call spell check AI. Next is autonomous AI, where AI works on its own and fully automates your routine work and lets you scale. So either you are in full control with spell check AI, or you take specific task and let AI do it end to end through this autonomous AI. And next is superpower AI. And by that, I mean AI that can do things that are not possible today. I'll give you more examples here, but the idea is for AI to do analysis at scale, to do analysis longitudinally, look at smallest of changes that are not possible, practically possible by humans today. And this has been, a good theory and concept, but how does it apply in the real world? And I'll give you an example from INEC. So we have capture AI that provides real-time image capture feedback. So when these retinal images are being captured, a real-time feedback ensures that the quality of images are good, and it has a very good downstream effect, making sure that patients actually get an actionable report rather than get a inconclusive or ungradable report, ungradable results. And that in and itself, many of our customers say, for example, saves them a lot of dollars just by making sure patients don't have to come back. Spellcheck AI is a human plus AI diagnostic service. So there are human graders who are grading these images as they would otherwise, but AI comes in to check for their work if they have missed anything or if they have missed certain diagnosis, improving the accuracy and also speeding them up. EyeArt fully autonomous AI system is our flagship product that allows primary care providers to detect diabetic retinopathy, for example, in the US, which enables normal patients to be excluded, and only those with disease can be seen by eye care providers. Superpower AI is our lesion analysis and longitudinal monitoring system. So it can look at smallest of changes that happen between successive visits and identify patients at the risk of disease progression, those patients who are progressing quickly versus not. So this is a framework that can be applied to many other domains. In fact, even outside of healthcare, where one can think of and analyze how AI can come in and help professionals in various ways, and looking at how this can be analyzed from a regulatory, clinical, and reimbursement considerations. Capture AI leads to moderate effort from a regulatory standpoint. Typically, it is part of a bigger system. For example, our Capture AI is part of our EyeArt system, which also does fully autonomous reads, but it can also be used on its own for our spell check or superpower AI. From a clinical standpoint, it's simpler. We only need a human factors study and retrospective analysis. You know, it captures value by improving efficiencies, and as I said, saves a lot of dollars by increasing the number of patients who have actionable report. Spell check AI, causes minimal effort from a regulatory standpoint, um, but there is a reader study that may be needed, and it also captures value by improving accuracy. Autonomous AI poses challenges from a regulatory standpoint, as well as from clinical standpoint. We need prospective study. We had to do a lot of work on reimbursement as well. However, at the end of it, we have a class 1 CPT code, category 1 CPT code that pays for this test. So with an autonomous AI, there is a precedent to justify this kind of direct reimbursement kind of value capture. And superpower AI is typically designed for specialists, and so regulatory process actually is not as challenging. We are not going to go for a specific reimbursement codes, but capture value through efficiency. But we do have to prove the effectiveness of these systems. So as we look at the future, we look at agentic and multimodal AI, which is where the world is moving. And I wanted to make sure we cover this and how we can analyze the the AI from our regulatory and compliance perspective. So agentic AI is AI-powered agents that can perceive, analyze, make decisions, take actions. These are specialized task runners that excel at very specific jobs. But what new we have here from before is that they do take actions. And so, rather than, let's say, scoring just risk, they can order follow-up. They can tell clinicians that, you missed this diagnosis, or they can pull the records, and they can add things to the medical record. And the challenge here is to prevent inconsistent actions. So, we need to put a lot of guardrails, but the potential is actually huge, both within clinical domain, but also outside of clinical domain. And multimodal AI is where multiple modalities are included in a single algorithm. For example, an algorithm that combines images with lab test and electronic health record to provide a comprehensive diagnostic output. And as we know, right, like healthcare by itself is multimodal. There is natural language, conversation with a patient, lab results, imaging, genetics, historical records, and so on. And this is an AI that can see, read, listen, calculate. And there are many challenges here, including technical integration, organizational issues, like organization may have these data very siloed, and getting them together may not be easy, and things like that. But make no mistake, world is moving in this way. And in fact, agentic and multimodal AI are very complementary, where, if we are going to take some action through agentic AI, we want to make sure that they are looking at all the data sources. And so for agentic AI to make safe decisions, multimodal input would provide that rich understanding. And on the other side too, when multimodal AI is making some inferences, we need to give them agency to act and intervene as well. And so this is where the world is moving, but it is also very exciting, but also brings number of challenges. So there are a number of examples, like AI that can detect patient's deteriorating conditions and summon a rapid response team, or a comprehensive AI care coach for chronic decision that can talk to patient, observe, review, and prompt action, right? So um, these this would be great because this now multimodal agentic AI can continuously manage and personalized care in ways that current episodic care cannot. So we could have personalized, quote unquote, agentic nurses for every disease, for every patient, monitoring them and helping these patients. So that's the holy grail, but it does, come with challenges. So uh, let me, also again put this multimodal and agentic AI into the framework that I just described. So today, for example, for Capture AI, we have, capturing gradable images. Maybe we have ambient listening AI, but that would move to multimodal perception where AI could listen, read, see, calculate to capture this data from the world in a structured way, in a way that minimizes noises putting into digital domains. Spell check AI today assists providers in reading images, providing clinical decision support, but multimodal AI can again continue to work in the background, but allow multimodal triage or spell check for therapies. Consider this, consider that kind of thing. Have you looked at this diagnosis? And bring up evidence around it. Autonomous AI is where a lot of agentic work can happen. So instead of just detecting disease, it can act on it. So analyze, decide, act, and in fact also reflect on what's going on. It Superpower AI, again, another holy grail of multimodal agentic AI, where hyper-personalized monitoring and care can happen, including things like digital twin, taking multimodal inputs and taking actions around that. So this, as I mentioned, does come with a number of challenges. Especially as we are here with CTeL looking at law and how things are changing quickly. Um, the FDA stance is changing quickly. FDA is in fact, or in general, regulators are lagging behind, and not surprisingly behind all these technologies. So how do we classify these devices? Are they a non-device CDS? Are they de novo or class 1 or class 2, or hopefully not, but class 3? FDA is also looking at locked versus adaptive algorithms. So although there is pre-specified change control guidance out there, but there have been no approved or cleared devices yet for adaptive AI. And that has been true for our own experience as well at INAC, where we have not been able to get a pre-specified change control protocol approved by the FDA. So the 21st Century Cures Act helps with device and non-device CDS definition, and certain situations where a doctor can look at why AI is making certain recommendations. They can be exempt and they can be deemed a non-device CDS, but there are a lot of restrictions. There have been a lot of work from FDA and other international bodies on transparency and machine learning practice. FDA also did a pilot around digital health research program, but that did not advance beyond pilot. So there is clearly some hesitancy around letting companies run wild, which makes sense. But FDA does need to recognize that these technologies have huge potential. The technology is moving fast, and regulation needs to catch up. Similar thing with data privacy, where training data sets, patient consent, security, all these issues are still being navigated, and also a huge, very quickly changing, stance around federal and state AI regulations, which may get simplified, I hear, but it still remains open. And then there are ethical and legal questions around bias and liability, like if it is an agentic or autonomous AI, who takes the liability if AI makes wrong decisions? And right now, the thinking is that AI device manufacturers need to do that, and that's what we do. So, before I conclude, let me just do more like a workshop, like discussion, and so feel free to chime in. But let's look at a case study, like AI diabetes coach that converses with a patient about their general well-being. It can ask patients to take photos of their food so that they can observe their daily activity, including from wearables like glucose monitor, but also their step counts and things like that. Review their medical records, labs, and it can prompt actions like scheduling checkups or medications. And as we analyze it under this framework as to, is it a medical device or not? And, which functionalities are medical devices? Is it de novo or class 3? What data is needed to support these submissions? And it all, like, kind of from a regulatory standpoint, it depends on, how far we go. If it is just alerting a doctor or a nurse, maybe it's simpler. If it is, actually adjusting medications, now it does get into, being a device. There are clinical considerations as well, and what kind of trials, what are the endpoints, as well as reimbursement considerations like separate CPT code or just capture value through um, you know value-based care and things like that. So here's the summary concluding this webinar. As these things are moving quickly, there are certain things that I would say developers should focus on, looking at solving clear pain points, engaging early with regulators, focus on integration, be mindful of bias and fairness for users, uh, budget AI as a strategic investment, include clinicians in their decisions, and nurture a culture that sees AI as a tool, not a threat. So I'll pause here. Thank you for listening. Happy to answer any questions or discuss any items.
Great. Thank you so much for your presentation. We've got a few questions in the chat we could go through. And if you have any additional questions, feel free to put them in the chat or raise your hand. But the first question is, what is a Category 1 CPT code, and how many categories are there?
Yes, great question. So there are basically three categories of CPT codes. The Category 1 CPT code is the most stable one. It's a permanent code. There is Category 3 CPT code, which are temporary codes, which are typically granted to emerging technologies or devices, and they get Category 3 CPT codes. CPT codes in and itself is a code. It's like a description of a procedure or description of a technology or basically a procedure. So in and itself, a CPT code does not grant payment or reimbursement. But this description allows for private insurers, or this code basically allows for private insurers or regional Medicare access contractors to make that payment. So hopefully that answers your question. The CPT2 codes are typically just information-only code, usually used for metadata or for meeting HEDIS and other 5-star quality measures and ratings. So most um, reimbursement efforts are around initially getting a CPT-3 code and then eventually getting a permanent Category 1 CPT code.
We have another question from Joe. Who drafted the clinical guidelines, and what role did iNook play in writing them, if any?
Yeah, so the guidelines are typically drafted by the bodies themselves. So they have a committee that drafts these guidelines, and INEC, along with another player in this industry, do engage with them to explain the benefits of AI and how it can help. In this case, diabetes patients meet their eye screening needs, which so far and even now, less than half of patients actually get that annualized screening. And so how can we increase the screening? So our role was in educating ADA and AAO, and engaging with them, sharing clinical data. And that's what leads to changes or of guidance across years of work.
The next question we have, could you please say more about the work you did to get reimbursement in place?
Yes. So the work that we did for reimbursement started with the first set of work in getting a code itself. So AMA is the one that actually creates this code. So discussion with American Medical Association on why we need a CPT code, which is like a description. Then we engage with CMS to assign a payment for it. And the first year in 2021, CMS did agree that a payment can be assigned, but it was left to the regional Medicare access contractors to actually assign these payments. So the work that we do is again producing health economic evidence, getting sending comments to the CMS on why they should pay, and proactively engage with the CMS um, on the need for paying for this technology and how it can help address these gaps around screening.
Another question we have, this is focused on chronic disease. Is there AI activity in routine optometry work, such as automating eyeglass prescriptions or enabling remote technician to work without optometrist review or cut diagnostic time for eye exam, especially in remote, undeveloped areas?
So I'm sure AI is so. So I must clarify that INEX work had this. This was not within scope of what INEX set out to do. I believe there are a number of tele-screening systems or telemedicine systems that can remotely give eyeglass prescriptions, but they are still optometrist driven, or there is an overseeing optometrist that enables this. Maybe this is something that is open to disruption, but at this time, I'm not aware of something that is fully autonomous in this space.
Looks like we've got a few minutes left. Are there any other questions? Feel free to type them in the chat or feel free to ask them live as well. And of course, if you have any questions after, feel free to reach out to the email you see on the screen, or feel free to reach out to the CTeL team as well. Do you have any closing words before we sign off for the day?
Uh, well, again, thanks everyone, and happy to take follow-up questions. I just shared my email. I would again say very exciting times with the multimodal AI, agentic AI set to disrupt our world. Thank you.
Thank you all for joining us for this webinar, and I hope you all have a great rest of your day.
Thank you, everyone.